Well, it's certainly my pleasure again to introduce to you Dr. Susan Wehry. Dr. Wehry received her medical degree from the School of Medicine at the University of Louisville in Kentucky, and her specialty is in geriatrics psychiatry. Now, through the years, she's developed a multifaceted career. She served as commissioner in Vermont, a consultant for CMS, and she's currently an affiliate faculty member for the University of New England College of Osteopathic Medicine. She's also well known in Maine. She's assisted in supporting the Maine Council on Aging, statewide policy projects that are currently underway. She's also known nationally for her consultation work on aging issues and is an established teacher and presenter, as you will see. I think that through the years, she's been here like 9 times with this particular conference. And no matter what topic she's presented, there's been some themes that have been woven into her presentations. Now, I believe that compassion is learned at an early age. I also believe that compassion is woven into the personality of an individual. And in all the years that she's been here, these are the threads that are running through her topics, okay? It's her passion for elders, her heart for caregivers, and her fierce advocacy for the right to self-determination of older individuals. So let's warmly welcome Dr. Susan Wehry. Okay, thank you.
Thank you. Thank you very much. Thank you. I really appreciate that very warm introduction and the warm welcome. I am so happy to be back in Maine. I feel this every time. I cross that line that says welcome to Maine, and I just get happy. So thanks for those 9 visits. Let's go for 10. And let me tell you how fortuitous it was that Sharon chose to start off by commenting on the very word in the title, compassion, not control. Because that's where I'm going to begin as well, is sort of unpacking, as we say, in this postmodern world, or dissecting the title of this talk, because this talk does also contain all of the major themes of the next 40 slides or so that follow. So we're going to really talk about what compassion is, why I think that it is the path to solving this challenge of at-risk older adults. But for the sake of your CEUs, let me start by reminding you of today's objectives. At the end of this hour that we spend together, you should be able to define, or have validated if you already know, autonomy, independence, and self-efficacy. But perhaps even more important than defining them, to really understand the major and the nuanced differences among those terms. You should also be able to have a heartfelt discussion about diminished capacity and how it in fact impacts, puts at risk, that self-determination of which, as Sharon has said, I have been a lifelong, and now it's a kind of long life, passionate advocate. And now we're going to think about how diminished capacity sort of threatens that. And I want to talk with you about a new approach to serving older adults that we actually borrow from the world of the disability community, which is a whole notion of supported decision-making. It's a little different than just having a commitment to autonomy when we serve as substitute decision-makers. Supported decision-making is kind of a broader and I think better concept, and it'll serve us really well in the aging community as well. So, let's talk about this title a little bit, and let me tell you about what I've been up to since I saw you last year, those of you who were here last year. Some of you may remember from our conversations last year that I had a sort of change of life, not that one, but a different one, experience last spring when I went to an intensive conference on compassionate care at the end of life. This was a course that was run in Santa Fe by a very well-known Buddhist teacher named Joan Halifax, who's also a medical anthropologist. She conducts an annual course for clinicians at her Zen Center in Santa Fe, New Mexico, called Being with Dying. And I went there because my own interest is expanding in end-of-life care. And while there, I really did have this experience of coming to terms with, how do you want to spend the rest of your life at any age? And I think I referenced this last year when I was talking about the notion of resilience, about the notion of being older, standing really in place at any age and saying, what am I going to do with the rest of my life? Okay? Well, that was a life-changing experience for me last year, this whole area of compassionate care, making sure I'm doing exactly what I want to be doing. And so it led to a series of things, including leaving my job as commissioner at the state of Vermont, going on a 12-week walkabout to Australia and New Zealand, coming back to really focus on this whole notion of compassion. So I couldn't thank you more, Sharon, for teeing that up so nicely, and it wasn't even prearranged. So what do I mean by compassion? Compassion, one way that I would describe it, is empathy in action. If you look at the world of neuroscience and you look at philosophers and neuroscientists coming together as they do in the Life-Mind Institutes, what people really appreciate about compassion is that it is empathy in action. Compassion, when you are cultivating compassion, you're actually activating the motor cortex. It's not enough to have empathy. It's not enough or even desirable to have pity. It's not enough to have sympathy. Empathy is a good starting point. Really standing in the shoes of another and understanding their view of the world, critically important. Compassion activates our desire to do something, even when doing something may be standing still. So compassion, I would differ from Sharon a little bit to say that it is not something that we learn in childhood. Compassion, I think, is an inherent human quality. What we do in childhood is to nurture it, or what I hope we do in childhood is to nurture it. Because compassion is that state where you say, there's a lot of suffering in the world, and I want to do something about it. To be able to do something about suffering in the world means really acknowledging it, feeling it, and the other studies that have been done on people who are cultivating compassion is that, frankly, compassionate people do feel other people's sufferings more. But the good news is that truly compassionate people, people who nurture this state, also return to their baseline state of feeling quicker, remarkably resilient. And so compassion is a state that we want to cultivate, and you're going to see how it relates to this whole issue of diminished capacity, I hope, by the end of my remarks this morning. So when you reflect on this word compassion, think, validating, standing in the shoes of, knowing the suffering of the world, caring about it, feeling it, empathizing with it, and committing to transforming it. That's what compassion is. Control sort of speaks for itself. Well, we'll come back to it later about how we tend to want to take control when we see somebody suffering, and how that may not be the most useful thing that we do. Now, the other interesting thing is, some of you may have heard this, I gave a similar talk to this a few years ago here, and I've actually been talking about how to support people who are at risk of losing their autonomy for most of my career, okay? This has truly been, as Sharon has mentioned, a big theme of mine. What's different now, again, and I used to call this competency, capacity, and control. Diminished capacity, supported decision-making, alternatives to guardianship. Before I'd ever had my life-changing experience last year, I actually started calling this compassion, not control, before I even knew what I meant. It's kind of interesting the way intuitive knowledge works that way. The other interesting thing is that when I talk about my work, I talk about it as service, serving older adults. serving at-risk older adults? Because I think language is really important, and I think serve is what we do. I found this cool quote from Naomi Remen, who says, the reason we talk about this as service, because when we use the word serve, we see life as whole. When we use the word helping, we see life as weak. If we want to fix people, we see them as broken. But serving sees life, sees world as whole. And so this title, Compassion, Not Control, Serving Older Adults at Risk, we'll talk what they're at risk of, really contains all the themes of my remarks. So you can sit back, contemplate it, reflect on it. You can listen to the rest of my remarks. But insofar as language really matters, keep this phrase in mind, along with make the magic happen in every day, or let the magic happen in every day. Think about what you do as serving with compassion, not control. Okay, now why do I care about this so much? Lots of reasons, but I'll tell you just one story and then I'll tell you some of the other reasons. Some of you may have heard this story before because it happened right here in Maine. I lived in Maine from 1991 to 1994. And during my time in Maine, I worked at AmHigh, and I also worked for what was then the Bureau of Elder Services. And one of the things that I was often called on to do in a variety of roles was to serve as a sort of expert witness, if you will, for guardianship hearings. And I was asked to do an evaluation of a woman who had Alzheimer's disease. There was no question about her diagnosis. And her family, based on that diagnosis, had gone and petitioned for guardianship. Why? Because they wanted to move her to a nursing home. She didn't want to go. So she asked for a second opinion on whether or not she had the capacity to make the decision to stay at home. So I was asked to do that evaluation. I evaluated her, and it was very clear that she had diminished capacity in some areas. She really couldn't and shouldn't be managing her finances anymore. She lacked financial capacity. She didn't understand her decision-making around money. She didn't understand. She couldn't balance her checkbook. But she had perfectly fine capacity with respect to medical decision-making. If you told her about some medical care that was being offered, she was perfectly able to understand the risks, the benefits, to state a preference, to understand the consequences of her decision. She retained one kind of capacity. She also retained the capacity to weigh in on whether she should stay at home with those attendant risks or whether she should move to a nursing home. And she concluded she didn't want a higher level of care. She was quite content to stay home, live with the risks, balancing against high quality of life. So, I go into court right here in Maine. I go into probate court, and I look at the petition, the petitioner's evaluation, 2 sentences. I'm a psychologist certified in the state of Maine to perform capacity evaluations. This person has Alzheimer's disease that is in need of a guardianship. Sincerely yours. That's the evaluation that got us into court. I come in with my very elegant, well-written, well-reasoned, impassioned plea to the court, explaining why, yes, this woman had diminished capacity, yes, she had Alzheimer's disease, but she didn't need a guardian, and she sure didn't need to be placed in a nursing home against her will. That in fact, not only would only satisfy on the surface one side of the equation, the alleged safety, but in fact ran the risk of impacting her health in a negative way, because when you take away somebody's rights, when you get somebody a guardian, they actually assume the legal status of a 6-year-old child. Having a guardian is not benign. I was even more passionate then because I was 30 years younger. Okay? So I go into court and I'm saying to the attorney and I'm saying to this woman, this is slam dunk. This is such a poor evaluation. It has one thing, she has Alzheimer's disease. It says nothing about her capacity. And I had assessed every aspect of it. So I'm in the witness stand and I'm feeling pretty sure of myself, maybe even a little cocky, hard to believe, I know. And I'm sitting there and the judge, so I give my presentation or my data or whatever, I give my testimony, and barely cross-examined, and the judge does one of these. Over the tops of the glasses. He looks at me and he says, that's all very well and good, Dr. Wehry. Do you agree this woman has Alzheimer's disease? Yes, Your Honor, I do. Dr. Wehry, do you agree that Alzheimer's disease is a progressive condition? Yes, Your Honor, I do. Then why are you wasting this court's time? Gavel down, case dismissed, guardian awarded, woman to nursing home, dies 8 months later. Okay? Now, I gotta tell you, that's the kind of life experience that makes you mad. Or it makes you worried, or it makes you impassioned, but it makes you want to do something about the level of ignorance that is in the way we approach people with some diminished capacity. The level of ignorance that we have, I think, about older people in general, about what people can and can't decide for themselves. So that experience really got me going. And the first talk I ever gave like this was in 1995, okay? Saying, it's not that sometimes people don't need support in decision making. It's not that we don't need a substituted judgment sometimes. It's that we need to do it in a way that preserves the dignity of people. We need to do it in a way that doesn't cause more harm than good. And that we need to know that there are actually ways to do it. There are ways to support people with diminished capacity. There are ways to serve them that don't require taking over from them. There are so many good ways to do this. This afternoon in the workshop, we're going to talk about, in a much more practical way, how you actually do those assessments and how you support those areas where capacity is diminished and support those areas in which a person maintains their own abilities. The other reason I care so much is because I'm a physician. And I've been a physician for 30 years. And there are certain things for physicians, like nurses, like nurse practitioners, like physician assistants, like social workers, like, oops, sorry, I don't have any place to clip this. I forgot that. I always wear a suit so that I have a skirt and I can hook this on it. My suit was in the cleaners, and I had to grab a dress and no belt. So apologies for the distraction. I'll just keep, that's why I keep waving this thing around. Like, what do I do with it? I've tried it on my sleeve. It didn't work. Anyway, I digress. So, back to our main story. So I'm a physician. I've been a physician for 30 years. And I've been guided throughout that, like all of us in our professional lives, and frankly in our personal lives, by some pretty clear ethical guidelines. We all live by certain codes. I have mine, you have yours. Here are some of mine. The first most important thing I have to do is no harm. I take that very seriously. So in my helper role, or now my serving role, I try to always keep this in mind. Do more good than harm. First, do no harm. It's the bedrock of my ethical obligations, and it's a good motto kind of to live by. But secondly, I do want to do good. Beneficence is the sort of official name for that medical ethical principle, is this notion of doing good. And unfortunately, I think in healthcare, this got very contaminated by these images. Father knows best. Father knows best. Who else have I got there? Marcus Welby and Dr. Kildare. Okay? One thing you'll notice, all men, and all men telling you what to do. So doing good this beneficence, I think kind of got a bad name. Over the course of my medical career, I have to say, we've kind of moved away from doing good because we don't want to be seen as paternalistic. I think we have to move back, particularly now that more women are in medicine and we know how to do good without knowing best. So we're not father knows best, we're mother knows how. And so we do good as a second ethical principle. A third ethical principle, and why I care so much, is I have an obligation to advocate for social justice. And another opportunity to do it. And this is part of the obligation. So even if I didn't care, even if I hadn't had compassion nurtured, and then finally our fourth ethical principle is to respect autonomy. Now autonomy, just to do a quick recap, you got to remember autonomy is not the same as independence. Oh, actually I'm not ready to do that. Respect autonomy even in the face of diminished capacity. So even when people have some decreased ability for self-determination, whether it is by something like Alzheimer's disease or some other interference, that even in the face of that, we respect autonomy and find ways to support it that balances all these obligations, doing good, doing no harm, advocating for a fairer world. Now, this matters so much now, I think, because we are still combating certain cultural stereotypes about what it means to get old, okay? What it means to be old, what it means to take care of aging parents, what it means to be oneself an older adult. And we're up against, I think, two dominant visions in the country. Here in this room, people I think don't share these, but we either look as aging as some kind of like, you gotta be a super ager running marathons to be called healthy, or you're seen as frail and unable to do anything. But we tend to get into these extremes, this either or, either super agers or incompetence, and we dismiss a lot of the real fears, the real worries, the real sense of loss, the depression, whatever it is, as just cantankerousness, and we have jokes like this. So we have to work really hard, I think, to avoid certain cultural stereotypes and certain family lore. Think about this in your own lives, about how does your family deal with its aging relatives? Think about it. Did you grow up with grandparents? Do you know your grandparents? Do they live in your home? Do they not live in your home, but you support somehow their life when they get older? Are they dismissed, embraced? We all grow up with certain family values that, again, for those of us who work in the area of geriatrics, compels us actually to think about those stereotypes. And because there are so many more of us now, it really behooves us as a culture, I think, to keep thinking about these things as well. We also care about this so much now, why it matters so much now, is that elder abuse, if not on the rise, is certainly becoming more recognized. We're becoming more aware of the problem of elder abuse. 1 in 10 Americans, older adults, people over the age of 65, are likely to be victims of abuse, neglect, or exploitation. That's over 5 million Americans. 1 in 10. And most of that abuse, neglect, and exploitation, like with children, is actually from people known to them. More often than not, families. So we gotta pay attention because families struggle, and one impact of struggling families is abuse, neglect, and exploitation. It's a big number. There's been a big increase in guardianship requests around the country. Now, Maine, I have to commend you, is in a little better position than many other states because you've had an Alternatives to Guardianships program going on for quite a while. You really should pat yourselves on the back for it because you're one of the leaders in Alternatives to Guardianship. But they're going up. And why? Because there has never been a larger intergenerational transfer of wealth than we're seeing now. We have never seen so many families struggling with how to care for an aging parent who in fact, for whatever reason, does have some diminished capacity, no longer has the capacity for self-care, and doesn't want more support. There's a lot more of that because there are a lot more of us. So let's look for a moment at Eleanor. Eleanor's 82 years old. Eleanor's daughter and 2 sons all live out of town. Eleanor's getting more frail. And one day her daughter Sheila, who lives out of town, gets a call from a neighbor saying, "I'm very worried about your mother. You know, I used to see her every day, maybe going down to pick up the mail or going wherever. I don't see her anymore. I'm kind of worried." So Sheila comes home, and she sees her mother in a state of self-neglect that she hasn't seen before. She's lost weight. She seems a little forgetful. She's not engaged the way Sheila has seen her engaged in the past. She opens her refrigerator, there's no food there, and her mom doesn't really have an explanation for any of this. She just says, "Don't worry." So Sheila, who happens to be a social worker, does what social workers do. She calls a family meeting. And the 2 brothers come from out of state, and they all sit down, and they say, "What are we going to do about Mom?" And Mom says, "I don't care what you do," essentially. She doesn't put it quite like that. "I'm not leaving here. I don't want to lose my independence." Because what the family decides is that Mom may need a higher level of care because she's clearly not able to take care of herself. Now, Eleanor's just been to her doctors about a month before, found nothing physically wrong, can't really account for the dwindles, if you will. But there you have it. And Eleanor ends with, "I don't want to lose my independence," and resists all efforts on the part of her children to get her any help at all. They say, "Mom, you can stay here, but would you just let a homemaker come in? This place is a wreck. This isn't the way you like to live. Will you accept Meals on Wheels? You're not eating well. Will you do this? Will you do that?" No, 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 no to everything. Sound familiar? Yeah, I see a lot of nods out there. So why wouldn't Eleanor, Mom, accept help when it's the very thing she needs to achieve her goal? This fear of losing independence is the thing you will most often hear from seniors. Now, I like words a lot, and I like words to be accurate, and I would say that when seniors, older adults, talk about not wanting to lose their independence, they may actually be talking about autonomy. And I'm not trying to clean up their language. But conceptually for us, I want you to think about this. Autonomy is not the same as independence. Independence really means I can do it myself. I'm self-sufficient. And it is a totally, totally overvalued concept in this country. 1, because it is an illusion. And 2, it leads to a lot of divisiveness. Why do I say independence is an illusion? Because I didn't design the car I drove over here in. I didn't pump the oil out of the ground. I didn't convert it to gasoline. I didn't make a stitch of clothing that I'm wearing. And I don't grow my own food. Okay? Most of you, many of you probably don't either. We are so interdependent. We depend on the love and support from family and friends to help us through a life that sometimes is hard. We need each other. We depend on each other, we rely on each other, and we all go strutting around saying how independent we are. I think it's overrated. I don't think autonomy is overrated. And if you need one more little hook to hang this idea on, I want you to think about Christopher Reeves. I want you to think about Stephen Hawking. I want you to think about people who are totally dependent on machines for every aspect of human function. Breathing, eating, eliminating waste, and who are in total charge of their destinies. They have autonomy, they have self-determination, and they're not at all independent. So one of the things we need to do, those of us who work in this area, is to make sure we're clear on what it is when we're supporting someone so that we can support that feeling, that desire to do it their own way. Autonomy, I think, got derailed in a lot of advocacy movements by focusing on the fact that autonomy is a right. We have a right to self-determination. It's actually embedded in the Constitution. We have a right to choose to self-determination. We have a right to privacy. It's a constitutionally protected right. And so it's had us thinking about autonomy in this kind of way, I think, in this, myself included, in this aggressive kind of advocacy way. They have a right to self-determination. It's an empty right if you can't carry it out. It's an empty, empty right. But it's there. It's in the Constitution, the right to be left alone. And very importantly, the framers of the Constitution said, not only do we have the right to be left alone, we have the right to do stupid things. They said it more elegantly. People are entitled to foolish, unreasonable ideas which do not conform. Okay? So we've tended to focus on this rights thing and kind of missed the point that there are actually a lot of threats to autonomy that we in the serving professions need to pay, I think, closer attention to. Because there are a lot of threats to autonomy. And there is a way to serve without taking control. What are some of those threats? The normative changes of aging may make it more difficult for us to recover from a hardship. If we become ill, it takes us longer to recover. If we break a hip, it takes us longer to recover than if we break a leg when we're 18. Okay? We're more sensitive to the negative side effects of medications. Things impact our ability to make decisions, impact our mentation, make it takes longer. People have to be a little more patient with us. It is harder, though not impossible, for us to learn. We want to memorize something, it takes us more trials. That starts happening at about age 35. We don't think about it till our hair turns gray or we start wearing bifocals. But it's been going on for a long time. We associate a lot of these negative things with aging that actually are, as I said, sort of lifespan activities. It doesn't mean that we can't learn. It doesn't mean that if people give us information in ways that we can use it, that we can't make perfectly well-informed decisions. But we have to be sensitive to the normative changes of aging. We also know from a psychological standpoint that this is a very active age. Late life is a very active age. But they are different challenges, and things that were important to us at 30, 40, or 50 may not be as important to us as what is important to us at 70, 80, and 90. And this is one of the huge challenges, I think, for families. And if you work a lot with seniors, older adults, and their families, what you hear often from adult children who are totally caring. So coming from a place of love, there's no question about it. And coming from a place of fear and frustration, they want to do what's right for mom. They want to do what's right for dad. And they always lead with safety. I don't want you to get hurt. I don't want something bad to happen. I would feel so guilty. Okay? Older adults ourselves begin to care a lot more about quality of life. Begin to care a lot more about accomplishing those things that we haven't done yet that maybe we still want to do. Of course we want to be safe. Of course we don't want to be afraid. Of course we want help. But if there's any inkling that to accept any of that means I lose any autonomy, I'm going to say no every time. Because what matters to me more than this abstract safety is preserving my right to self-determination, to live a life that's meaningful and full and so forth, however I might define that. That's kind of the difference here, I think, between one of the challenges between adult children and their parents. The other thing is that as people get older, social roles change as well. It's another threat to autonomy, particularly around abuse, neglect, or exploitation. Because one of the ways that people identify when friends or family are in need is in the workplace. But if you're no longer in the workplace, if you live in relative isolation, then you are in a more vulnerable spot for being exploited or abused and nobody finding out about it. Again, normative changes that go along with getting older. These changes matter. It matters that we acknowledge that while there are so many benefits, and that's actually probably more important than the challenges, at every age, different risks are there. And at the age of older adults, these are some of the risks to autonomy, to directing one's own life. Now, non-normative changes, of course, are also there. By non-normative changes, I mean that not everybody gets dementia, but older adults are at a higher risk. That absolutely puts capacity to make decisions at risk. Depression, which if we go back to Eleanor, is what we'll figure out she probably has, really impacts decision-making, really impacts self-determination, because it's harder to care when you have clinical depression. You have this loss of pleasure, this unhappiness, and you get this kind of tunnel vision of thinking. So your problem-solving skills go way down when you have depression. That's not normative aging. That's a treatable condition. To begin to get the idea of how we approach this a little bit differently, we can say about situations that we face, what's the barrier here to autonomy? Not what is the condition that just needs to be treated. It's kind of the way of thinking about this. Same way with substance abuse disorders, and then abuse, neglect, and exploitation itself, of course. The net result of all of these normative changes in bodies, in your body that has to be accommodated, changes psychologically that have to be accommodated or assimilated, developed from, and so forth. The net result of all of this, I'm increasingly appreciating as the people who are older than me are a lot older than me, right? Meaning that now in my 60s, it's people in their 80s, whereas in my 30s, I was perhaps seeing people in their 60s more often. People are afraid. People are afraid of losing their autonomy. They're afraid of living in isolation. They're afraid of accepting help because they might lose their autonomy. They're really afraid, particularly older adults in their 80s who have well-intentioned children. They're really afraid of hurting them. They're really afraid of being abandoned by them if they don't do what their daughter says or their son. And I think that it is one of the great challenges of our age is the amount of fear that is in the country. We have become a fearful people. We're afraid of everybody. And I got to tell you, I mentioned at the beginning that I'd been to New Zealand since I saw you. If anybody wants to go spend some time in a country where people aren't afraid, go to New Zealand. It is absolutely extraordinary to be in a country where you don't see signs posted everywhere, no trespassing, where really when you fly within the country, you never have to take your shoes off. Nobody looks in your bag. You get on and off planes, people are friendly one another, people look at each other in the eye. You can hitchhike, you can pick up hitchhikers, you can camp alongside the road. Now, yeah, I did all those things. And I know that they sound like, I don't know how they sound. To me, when I say them out loud in a crowd, which I hadn't done before, they sound kind of brazen, foolish, silly, trying to be like I'm 20. No, actually, it's what you start doing when you're not afraid. And it's a great feeling to live with less fear. And I think fear is one of the greatest challenges, one of the greatest enemies, is the way Joan Halifax talks about it, one of the greatest enemies to compassion. One of the greatest enemies of compassion, of standing in somebody else's shoes, being willing to have their suffering, making a commitment to transforming it. One of the greatest barriers to actually doing that is fear. Fear of your fellow man. And so I now am expanding my sort of advocacy to wanting to help people not live in fear. Because I think fear is really one of our greatest burdens at this particular moment. This is also, the net result of all this is also why older people tend to get more anxious when their decisions are challenged. They begin to doubt themselves because their families doubt them. They begin to doubt their own wisdom. And then you get that thing that Eleanor does, no homemaker, no Meals on Wheels, no nothing, because they fiercely feel that they have to defend what most people call their independence. And so you end up with this kind of stalemate. Respect for autonomy, which is bedrock with me, is totally necessary, but it's not sufficient for us to do our work. Because there are so many motivators and triggers out there for people to want to take control. And so we need to expand our repertoire to something more than just fierce advocacy for self-determination. We need to be ready to address those safety concerns that people have. Big ones being from falls, protection from exploitation. We need to be ready to say, yeah, that safety problem is a real one. And I'd admit it too. If I weren't so afraid, if I admitted anything, you wouldn't want to take away my autonomy, okay? People are willing to take help if they're not afraid that somebody's going to take control. So we want to, or at least my new approach, is to address that fear and frustration and love that children have for their parents and give it weight as well. You know, if you're always in the defenders column, you know, as I was in 1994 on a judge's bench, saying she has the right, I missed how scared those kids were, how scared her husband was, that something bad really would happen. Because I was very preoccupied with defending her. Now, I would defend that just as fiercely, but I also step to the side and stand in the shoes of the child, the adult child, and say, I get why you're afraid. Do you get why your mom's so afraid of accepting any help? Can we make our focus diminishing fear? So, these are the things that people tend to be afraid of, so we address those rather than just picking one piece of the pie and supporting autonomy. These are some of the other triggers, and I'm not going to read them all to you. You have them in the handout if you want. But you know these situations well. When someone like Eleanor begins to decline, when somebody with a substance abuse disorder begins to drink more, shows more decline. These are the things that trigger the wish to take action, to take control, to get a guardian, to make somebody move, to move them to a higher level of care. Whatever it is. Things trigger that kind of action. We want to step back, we want to take a step back and trigger action coming from a different place where we use our skills of empathy, but we don't sympathize, we don't take pity. We don't always get caught up in our own moral outrage. We say, I get it. Fear, risk, these are real things. And this is where I think we want to find ourselves. Our best way to serve and support at-risk adults is, in fact, to find a balance among all these concerned and among all the concerned parties. One way we do that is to enhance self-efficacy. Self-efficacy is simply that sense or that condition of knowing that you impact your world. And I've mentioned this example, I think, here before. If you are in a nursing home setting, for example, working with people with really quite impaired capacity, people with advanced stages of dementia, you hold up a red sweater and a blue sweater, and the person with dementia nods towards the red sweater, like maybe they mean that's the one they want, and you put that red sweater on them, that person with profound impairment has just experienced positive self-efficacy. And it turns out positive self-efficacy is very good for our mental health. And self-efficacy is a concept you can take for any state of being, but it's, I impact my environment. If I, again, am nonverbal, you serve me warm oatmeal, and I throw it across the room, You don't say, I'm a behavior problem. You say, I guess she doesn't want oatmeal. You don't give me some medication to lower my agitation. And then serve me oatmeal again. Because I'm going to knock it off the tray. Okay? That's the difference here. It is seeing the world from the person's point of view and understanding behaviors as communication. And whether I have any ability to know your name, to know what you're serving me, if I knock my oatmeal across the room and you say, oh, sorry, you usually like oatmeal, let me get you some toast. And I eat it, or that seems to be what I want, or if I knock it across the room and you say, I guess you're not hungry, and you leave me alone, you understand my communication, I experience self-efficacy. That's kind of what it is. Oh, and there it is on the slide. I'm responsible, I'm in charge, what I do makes a difference in my world. Now, every single thing that you do in whatever work you are in, whatever relationship you're in, with a young person, a middle-aged person, an older person, is an opportunity to enhance self-efficacy. Everything you do. Any kind of care, partner, relationship, scheduling visits, whatever you do is an opportunity to enhance self-efficacy, and it is critically important for bolstering the self-esteem, particularly of older adults, who is experiencing a risk to their autonomy by their diminished ability to take care of certain things for themselves. Another way that we do this is to engage everybody's full circles of support. I think some of us, particularly those of us who have been in caregiving professions or advocacy positions for a really long time, have a tendency to see ourselves as the heroes. We have to do it all. I'm not sure that we always play an active enough role in engaging the full circle of support, the natural circles of support, bringing a lot of people in on any situation that needs to be addressed. I think that we really have to take this notion of language seriously when we talk about identifying health goals and demedicalize our lives. When we're trying to help somebody achieve a health goal, it's not to achieve a certain lab value, it's not to achieve a certain blood pressure number. It may be to reduce the medicines that we're on. But generally, when people have a health concern, it's because they have a very specific goal in mind. Many of you have heard me talk about my mom over the years that I've been coming here. My mother was hospitalized for the first time since childbirth, last fall. Her goal was, of course, to get out of the hospital for one, but to be able to walk again because she's become quite short of breath. She now has a rolling walker. And she sees it as a tool of her independence, not as a crutch. These habits of mind, these attitudes towards things really, really make a difference. And so we need to find out when we're trying to engage somebody, for somebody to be less so-called help rejecting, which is the way we usually describe it, or non-compliant or non-adherent, they just say, no, what about this matters to you? You want to be able to get out of your apartment and do more things for yourself? Let's make our plan on that. Not, my goal isn't getting you to accept my treatment plan. Our shared goal, there's some knowing laughs on that, okay? Because usually professionals tend to talk about convincing people to do what we want. But it's really to finding out what they want. Then if we have some knowledge to share about how they can do it. If you're a person who does home visits, a little thing for self-efficacy is just create the control points, turn them over to the person. What time you come, how long you stay, what day you come, to the extent possible. None of us get everything we want. But we try to have a habit of mind that says, who's really in charge here, and it's the person we're serving. It's kind of that simple. I think also, we don't have time to talk about this in detail, but we really, really, really have to start paying more attention to end-of-life care, to palliative care, and to start having those conversations among ourselves, families, friends, and with our health teams about end-of-life. And I was so glad to see that several of the sessions here in the conference are an opportunity to really talk about the 5 questions about palliation and about end-of-life care. So, This notion of supported decision-making basically says that when we encounter a person with diminished capacity, and remember, the difference between competency and capacity is that competency is a legal concept. Competency is something you have until a judge takes it away, okay? In this country, it's sort of like innocence. You have it until you're proven guilty. We're protected, we're assumed to be competent until somebody has proven that we're not. And proving that somebody is not really is a matter of assessing their capacity, which is the ability to do something in multiple areas. The capacity to make a will, the capacity to make a contract, the capacity to make healthcare decisions, the capacity to make informed decisions about end-of-life care, lots of capacities, but it's about being able to do something. And not being able to do one thing, like not being able to manage your finances, does not mean you can't do other things. And this is why I had for so long been such a champion of limited guardianships, but I think supported decision-making is even a better way to go. When you assess that somebody lacks an ability to do something, they lack capacity in some particular area, you don't think about ways to limit taking that over. You think about ways to remove whatever the barrier is to their ability to do something. Just a slight nuanced shift. What is in the way of this person's decision-making? So let's say, for example, since we're borrowing this from the disability community, let's say that the decision to be made involves a lot of complicated mathematics. And let's say a person with an intellectual disability can't actually do any of it and can't actually even get the concepts to do any of it, no matter how much you support it. So how does supported decision-making work in that scenario? Well, the way supported decision-making works in that scenario is to say, let's not focus so much on the skill that needs to be made, but on the consequences of that decision. What is the input that's needed here around financial decision-making? What is the real goal here? To protect the person's investments, to protect their savings? What are we trying to accomplish? And what is the person's idea about that? What are their goals? And help them articulate that. And then, to the extent possible, you might be in a position of saying, well, if you had a choice between spending your money here or spending your money there, what's more important to you? Really ask people what they think they would like. And then in the broader context, to decide whether that decision can be made without doing harm. And supporting it even if we don't like the idea. It's all about giving the person as much opportunity to be in charge of their own destiny, and we supply the missing skills. That's really kind of the attitude there in supported decision-making. I think that the path, if you will, or the attitude, or the condition of mind that helps us move away from these either-or, either I decide or you decide, whether this sort of divisive, either you're safe or you have a high quality of life, this sort of either-or thinking that we get into, that what the attitude that will help us out of that is this notion of compassion. That it is compassion that allows us to stand in the shoes of a person who is older and to really understand their fear of reprisal from their children, to understand their fear of being alone, to understand their fear. I think the greatest risk is to the loss of autonomy, their fear of losing that, and to take a role that says, you don't have to be so afraid. Let's, in fact, identify what pose the biggest barriers to your retaining being in charge of your destiny. Let's solve that problem instead of trying to solve the problem of guardianship or limited guardianship or whatever, and to kind of get this conversation back on a track where compassion and not just passionate advocacy is really our guiding principle. So I want to thank you for your kind attention. We have an opportunity for questions and maybe not answers. I know I never allow enough time for questions, so I'm trying to do better this year. And because it's coming right up, I need to make one public service plug for June 15th, which is World Elder Abuse Awareness Day, and to ask everyone to visit the World Elder Abuse Awareness Day website. Find one action to take, one thing that you can do to help reduce elder abuse.
So, Susan, I actually have 2 points before I pass the microphone. One is you talked about the person that really had difficulty with finances.
Yes.
It could be that she always had trouble with finances, that it's not just because of her older years that she's having trouble. True? Because
Absolutely.
we find that with people with head injury, that they have issues that they never had before, and then just because they have a head injury, they're expected to be able to organize a meal when they never could before.
Absolutely. So let me say a couple of things about that. One is that, I focus on older adults because that's our topic here. But absolutely, people can have difficulty, like with any aspect of life, throughout the lifespan, with or without a head injury. There are some people who shouldn't be managing their own finances. Some of you are married to some of them. Some of you are one of them. Okay, I get it. Okay, so I think, and we see particular capacities. I was going to say destroyed, but that's a little bit too strong. Impacted by things like a head injury. So the issue here is, the point about this is that when people have any barrier to autonomous action, we focus on how to remove that barrier. So nowadays it is so easy to support somebody with diminished financial capacity because of things like direct deposits, because of people. You don't actually ever have to touch your money. Now, you might have your own concerns about everything being online, but actually a lot of things can be on autopilot. They can be made a lot easier. But the decision making about that money, about how it's spent, how it's saved, how it's distributed, whatever, is something that even people with head injuries, with dementia, can have a voice in. That's really the thing, is to get people to have a voice in it. But yes, it can happen at any age.
Questions?
Cliff.
Cliff? Sorry, Cliff.
Thank you. That was wonderful, Susan. And I don't really expect an answer to these questions, but I want to pose them as sticky situations, and those are ones in which we have a regulatory responsibility. And the situations that come up most often have to do with either self-neglect or driving. Driving's a little easier because there's the public safety issue there, not just the safety of the person involved. But we're not very good at predicting who's safe and who's not a safe driver, nor do driving evaluations necessarily tell us very much. So that's, and that's such a loaded issue for people, very, very challenging clinically. But then there's self-neglect, where we have a little more clinical freedom, I think, to use our judgment. How do you approach those situations where we also have regulatory responsibilities?
So, it's really two questions. States vary in terms of how much regulatory responsibility somebody has about people not driving. One of the things about not driving for me is that there are a lot of people who are really bad drivers. They are anybody from the age of about 18 to 25 who is texting while driving. Well, actually, anybody at any age texting while driving, right? But it's just that at certain age groups, people are more likely to. So we have a problem with safety on our roads. There's no question but that beyond a certain age, response time goes down, reflexes are slower, and so we need to have, in my mind, from a regulatory standpoint, a comprehensive approach to road safety, okay? That includes how to make it easier for people to voluntarily give up driving, as well as to regulate. This is one of the biggest things in an automobile-driven, that didn't mean a pun, but an automobile-driven society, particularly in rural states like Maine and Vermont, where you really need a car to get around to see your friends, to go to church, to buy your groceries, to get to the doctor, work, whatever it is. So I think that if we're going to talk about a regulatory approach, it is incumbent on those of us who are leaders in this area to demand a comprehensive approach to road safety and not just single out older people as people in need of having their driving restricted. I really believe that if conversations start early enough, and if the barriers to making a good decision are removed, at least in part, that more often than not, older people voluntarily stop driving. Not all of them. But it takes an early conversation. It makes you know, so how are you going to get around? How is this going to happen? So I have a lot of confidence in older people doing the right thing. When it comes to self-neglect, again, the state rules on this in Vermont and Maine are very different. And we don't approach it from a regulatory standpoint. We approach self-neglect in Vermont like this. We basically say, given their druthers, most people would prefer to have food, shelter, clothing, to be free from pain. We say basically, even people who are self-neglecting probably follow the same Maslow rules of hierarchy. We don't like being cold, hungry, thirsty, living in fear, not having a sense of safety and security. So you look at people who have self-neglect and you say, well, they seem to be choosing to live differently. I don't buy it. I think that if people are living in pain, squalor, etc., that in point of fact, something is interfering with their ability to have their own balance be different, which is to say, really given my druthers, I'd rather not be cold and hungry. But if I accept any help, I'm going to go to a nursing home. That I think that what we have to do for people who self-neglect is to first identify what is the barrier. As often as not, it's one of the 3 Ds. Actually, it's one of the 4 Ds. People who are at higher risk of self-neglect have dementia. People who self-neglect are at higher risk of having clinically significant depression. People who self-neglect are at much higher risk of having a significant substance abuse problem, particularly in the age group 80 and above, alcohol abuse disorders. And then finally, the 4th, less common in terms of its frequency or its prevalence, is paranoid disorders. People who self-neglect have delusional disorders, beliefs about the world. So one thing I think that we do for people who self-neglect, I think from a standpoint of policy, is that we need to have a concerted team approach to people who self-neglect. And that includes having a full, I don't mean necessarily diagnostic, but having a mental health evaluation. Because oftentimes when you can address the depression, the dementia, the substance abuse, or even simply the polypharmacy, that people have adverse drug reactions and are so confused any of us would be living in self-neglect because of the impact of those drugs, okay? So I think how I approach it is to say, first of all, what's causing it? Because I think people prefer not to suffer. It's an assumption, but it is one that I have. If they seem to be choosing to suffer, it's because there's a greater fear in their life, and I believe that it is the loss of autonomy. And I think that's the greatest knowledge that comes to me by approaching things through this lens of compassion, is that if you really stand in the shoes of people like that, you will see just how afraid they are. And they are afraid either from some paranoid place or they're totally afraid of losing autonomy. So I work really hard to find a way to have people live in less neglectful conditions without sacrificing their autonomy, because that's what they're afraid of losing. And if I can engage people, and it's not just of me, if I can get the natural supports in that person's life and the professional teams to understand that our goal is not to find the hammer that we can use to pull them out of a squalor situation. Our goal is not to get them to accept a guardianship. Our goal is not to get them into a higher level of care. Our goal is not to intervene aggressively, but our goal is to restore them to a state of well-being of their design, okay, but that protects the public health of others. Because I get that sometimes other people's lives are impacted, particularly in, kind of community dwelling situations, apartments, whatever, where there might be fire hazards, there's public health safety. But though we tend to focus on those are the exceptions. Those aren't the rule. The rule is most people have gentler levels of self-neglect. And that's when their families want to take action and move them to something else where they'll be safer, better looked after, well taken care of. So that's the way I think about it.
So Dr. Wehry will be having a session this afternoon, a workshop, and please give a healthy round of applause.
Thank you very much. Thank you very much. Thank you.